Okay, let's dive right in. Think for a second about the incredible, intricate network of signals that lets you do, well, anything with your hands. Picking up a cup, typing, steering a car. Now, what if that connection was just cut? Today, we're going to explore the amazing surgical techniques that can actually restore movement to a paralyzed hand. It's like literally rewiring the body's own system.
And this is the reality for someone with a high radial nerve injury. It's called wrist drop. And what it means is that the basic, fundamental ability to lift your wrist and straighten your fingers is just gone. And without that stability, the hand has no power.
So yeah, that's the big question, right? When that nerve, the body's electrical wire, gets damaged, the muscles it controls just go silent. The brain's sending the signal, hey, move, but the message just never gets there. So how on earth do surgeons fix that broken link?
It's absolutely devastating. You know, if you ask someone with this condition to squeeze something, the wrist just collapses. They have zero grip strength. It's not just about not being able to lift your hand. It's about not being able to interact with the world in the most basic ways.
So before a surgeon even thinks about picking up a scalpel, they have to play by a really strict set of rules. The body itself has to be a good construction site for any of this rewiring to even have a chance of working.
Think of it this way. You can't install new wiring in a house that's falling apart, right? So the skeleton's got to be stable, the joints need to be flexible and mobile, and all the skin and tissue around it has to be healthy. But just as important, you see that fourth one? The patient's own goals.
And this quote from a surgeon just nails it. This isn't just some mechanical repair, it's a partnership. The surgeon has to know what the patient actually wants to do. Is the goal a super powerful grip, or is it more about fine motor control? Because if a patient goes in expecting a perfectly normal hand, they're going to be disappointed. Managing those expectations is step one.
Okay, so the stage is set. What's the first solution on the table? Well, the classic approach is something called a tendon transfer. If you think of your tendons as the ropes that your muscles pull on to move your bones, well, this surgery is all about rerouting those ropes.
So what the surgeon does, basically, is they borrow a healthy working muscle and tendon unit that the body can spare. They detach it, move it over, and then hook it up to a new spot to do the job of the muscle that's not getting a signal anymore. One tendon, one new function.
What's so cool about this slide is you see the contrast between the plan and the reality. On the left, that's the surgeon's blueprint, drawn right there on the patient's arm. And on the right, well, that's the operating room, where those lines on the skin become this incredibly complex work on living tissue.
And this shows a really key point. There's no single right way to do this. Surgeons have to choose from different sets of transfers. So for instance, if you look at the table, using the FCR tendon, that's great for keeping the wrist stable. But using the FCU tendon can give you a much stronger result. But, and it's a big but, it comes with a 50% risk of the wrist pulling off to one side. It's a calculated trade-off, and it's all based on what that specific patient needs.
So that's the mechanical approach, right? Moving the ropes around? But what if you could fix the electrical problem directly? Instead of rerouting the ropes, what if you could restore power to the original muscle? Well, that's the whole idea behind solution number 2, nerve transfers, or splicing the wires.
Okay, so this is the fundamental difference, and it's really important. A tendon transfer, it moves the action. It hijacks a working muscle to do a new job. A nerve transfer, on the other hand, moves the signal. It takes a branch from a healthy nerve, a live wire, and plugs it directly into the nerve of the paralyzed muscle, trying to wake it up and switch it back on. And this technique has some incredible advantages. I mean, because you're waking up the original muscle, the movement can feel way more natural, more intuitive. You don't have to sacrifice a perfectly good tendon to do it. And it's opened up whole new worlds for people with really devastating injuries, like tetraplegia, where you just don't have a lot of spare tendons to borrow.
But this procedure is not without its challenges, and one of the biggest ones can be summed up with this single ratio. So what on earth does that mean?
This is what's called axon mismatch. Axons are the tiny little nerve fibers, the individual wires inside the main cable. In a common procedure, the donor nerve might only have one little wire for every 5 or so in the nerve it's trying to power up. It's kind of like trying to power a whole factory with an extension cord you plugged in at your house. Sure, you might get the lights on, but you're not getting that full industrial strength power back.
So the mechanical or electrical work is done. The surgery's over. But in a lot of ways, the most important part of this whole journey is just getting started. And it doesn't happen in the hand, it happens in the brain. Right.
The hand has been totally replumbed, but the brain is still working off the old blueprints. The patient now has to consciously retrain their brain. With a tendon transfer, for example, they have to learn that the old command to, say, bend their wrist, now actually extends their fingers. It's a complete mental override.
And that re-education, it's an intense process. After about 6 weeks of being immobilized so everything can heal, the real work begins. Therapists use tools like EMG biofeedback, where a screen literally shows the patient when they're firing the right muscle. They use special splints to guide the hand, and then it's just repetition, 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 until the brain slowly writes a new program and the movement becomes automatic again.
Now here's something that is absolutely critical for all of this to work: timing. This data is pretty striking. Patients who get their surgery done within a year of their injury are 2.4 times more likely to get complete motor recovery. If you wait too long, the muscles start to waste away and the joints get stiff and the whole thing gets way, way harder. And speaking of the brain's ability to adapt, get this, it's just a fascinating peek into neuroplasticity. Therapists say that kids, they learn these new movements almost instantly. You show them one time and their brain just gets it. For adults, it's a much longer, more conscious slog, which just shows you how incredibly adaptable a young brain is.
This quote from a surgeon really puts it all in perspective. The surgery, no matter how brilliant it is just one piece of the puzzle. Without a dedicated therapist and, most of all, a dedicated patient, those fancy transfers just aren't going to reach their potential. It is a true team effort through and through.
Which brings us to our final thought here. When we see a hand that's been brought back to life like this, are we looking at a feat of pure surgical mechanics, of moving ropes and splicing wires? Or is the real miracle happening up in the mind, a testament to the brain's incredible power to just redraw its own maps? The answer, of course, is that it's both. And that's what makes this so amazing. It's not just about rebuilding bodies. It's about rewriting what we thought was even possible.